Good morning. Welcome back. And yeah, huh? No, I am not that gentleman, but I play him on TV. So I think I'm up here for an hour, but we will do some exercises after this talk. So this is a talk about MRI imaging, and it's a straightforward talk about imaging in epilepsy. And imaging is pursued to establish etiology, which in turn provides prognostic information and guides further evaluation and therapy, and it directs treatment. It does so to identify potential candidates who may benefit from epilepsy surgery, to confirm a focus which is critical for epilepsy surgery, and functional imaging is performed to identify areas that you don't want your neurosurgeon to remove during epilepsy surgery. So there are different levels of findings. The imaging can be normal, or you can have nonspecific findings that are not relevant to the care of the child, such as periventricular nuclear malacia or arachnoid cysts. It helps to identify or confirm remote static lesions, such as old strokes or suspected malformations of cortical development, and it can identify cause based on a pattern of subtle abnormalities. So, for example, HIE. Certain genetic syndromes have patterns of MRI abnormalities that allow you to get the diagnosis, such as Walker-Warburg, and also metabolic syndromes. You can identify the cause of epilepsy that does not require urgent intervention, but may be potentially amenable to surgery here, thinking of focal cortical dysplasias or cavernous hemangiomas or similar entities. And you could identify subacute processes with clear therapeutic and diagnostic implications, such as someone with a brain tumor, someone with leukodystrophy, or someone with metabolic cytopathy. And occasionally you can diagnose an acute process which requires acute intervention. So who to image? So I live in a place with lots of resources, so my answer is everybody. And there are those that you do not need to image, such as those with a childhood absence epilepsy or what is now deemed self-limited epilepsy with central temporal spikes. But fundamentally, any child with evidence of focality on history or exam or EEG, any child less than 2 years old, because these children rarely have what would be called in the old days a primary generalized epilepsy. It's almost invariably focal. Anyone with a symptomatic generalized epilepsy, and any failure to, and if you have limited resources, and anyone in whom you are not able to achieve control of seizures, or there is deterioration in the epilepsy or the developmental status of the child. And I would also say anyone with new onset seizures with a medical emergency. There's no need to image if the EEG and history indicate classic absence epilepsy, JME, or SELEX. And there you image only if the course is not typical. So you can use CT, and you can use structural high-resolution MRI epilepsy protocol. There are a variety of other techniques which I will not be talking about today. So CT is much more available, but really it should only be used in an urgent situation when MRI is not available. It's very good at identifying bone and blood, or calcium in blood. It can identify semi-acute stroke, CNS bleeds, large tumors, abscesses, and other such entities. However, false negatives are common, providing false reassurance. So a normal CT does not get you where you need to be. And it also confers radiation. There are specialized protocols to limit radiation in children, but they are not ubiquitously employed. So here are just some CT images, which you will all be familiar with. Obviously, someone who has bled into their brain, someone with an acute stroke, the calcified lesions of toxoplasmosis, and the lesions of cysticercosis, or worms in the brain, and a not very subtle brain tumor. But CT will miss small brain tumors, it will miss early stroke, and it will miss mesial temporal sclerosis, among others. Okay. So the International League Against Epilepsy Diagnostic Commission, Subcommission on Imaging, recently published their update on imaging in adults, which is the Harmonized Neuroimaging of Epilepsy Structural Sequences, or HARNESS MRI. And here, this sequence really is designed to identify focal cortical dysplasias and subtle malformations of cortical development. The acquisition sequences here are a 3D T1 image at 1 millimeter cubic resolution, a flare turbo spin echo. These people watch cartoons as children. Of 1 millimeter cube, so that's 3D flare, also 1 millimeter cube, and a very high resolution oblique coronal T2 weighted perpendicular to the hippocampal formation, which has a very fine resolution. And they also advocate post-processing. So this is really excellent for people who are older, and in the older sequences, in the older recommendations for pediatrics, the recommendations were similar, except using T2 imaging in 2 planes and a similar sequences. And the main issue here is that gadolinium contrast really is not necessary in anyone with epilepsy unless you seriously consider tumor or inflammation as an etiology. The standard protocol is best applied at 3 Tesla. So 3 Tesla units confer some advantages to 1.5 Tesla, and there is some data to suggest that 7 Tesla confer advantages to 3 Tesla machines. It is really, really important to decrease the slice thickness. Because the width of the cortex is 2 millimeters, you have to be able to image at 1 to 2 millimeter resolution. Otherwise, you will miss subtle focal cortical dysplasias. And if you are imaging at 4 to 5 millimeters or do post-processing imaging at that, then you will miss those lesions. There are some pulse sequences that are not used in common practice, and there are case reports of their utility in particular cases, and these are magnetization transfer, MR spectroscopy, and susceptibility weighted imaging, and DWI, and ASL. The main point that I wish to make is that if you are imaging an infant defined as anyone less than 24 months of age, because of the maturation and myelination, which begins from the inside out and in the middle to the ends, that change in signal associated with development and maturation of myelination makes it very, very difficult to identify focal cortical dysplasias that can be the size of my hand. And you will miss those with T1 and FLAIR imaging. So it is essential in infants, and I would also say it's also important in people older than infants, to use T2 weighted imaging in at least 2 planes. Our practice is to do axial and sagittal imaging. Others will use coronal imaging, and they should be at least 2 millimeter resolution. So if you're imaging infants, you have to have T2 sequences in 2 planes. Why is this important? So this is data from Ann Berg's a project looking at new onset epilepsy in infants defined as less than 24 months. Within 1 year of diagnosis, almost everybody used an epilepsy protocol, mostly at 3 Tesla. Almost everybody underwent this protocol, and out of the 700 patients that they imaged, one was able to identify an abnormality on MRI in about 40% of the patients, but in 1/4 of the patients, the imaging abnormalities were relevant to the etiology and treatment of that child. And importantly, 10% were identified to have lesions which were potentially amenable to surgery. So at the outset of epilepsy, high-quality imaging gives you a cause in 1/4 of patients and allows you to detect people who may benefit from surgery earlier rather than later. This is just a list of some of those things. These are acquired, mostly acquired or structural abnormalities. And there's also a similar study by the Brits looking at 2,000 patients with new onset epilepsy using an epilepsy protocol. They excluded new onset seizures and generalized epilepsy, and again identified 36% abnormal, similar to the pediatric series, 20% abnormal and relevant, And in this population, you also identified mesial temporal sclerosis, which you don't see so much in the babies, as well as tumors in 5%, whereas in pediatrics it's about 1%. And again, approximately 15% of findings were potentially amenable to surgery. So part of this is, you need to know the cause to direct treatment. But one of the treatments one should be thinking about is the person potentially amenable to epilepsy surgery? And if you look at patients who undergo epilepsy surgery, then you will find, and this holds up, this is data from the 2004 surgery survey, but it holds up still. 40% have a focal cortical dysplasia or malformation of cortical development. 1/5 have a tumor. 1/10 have evidence of a vascular abnormality, a stroke. 7% have mesial temporal sclerosis. And then you get a variety of pediatric syndromes, TS, hypothalamic hamartoma, Rasmussen's, and Sturge-Weber, among others. So the top things you're looking for are malformation of cortical development, including focal cortical dysplasia, tumor, vascular abnormalities, MTS, and something else. And that's what we're going to go through. And the reason this is important, and you see this slide at least 3 times a year if you listen to me talk, is that if you look at surgical outcomes, and this is 1,000 patients operated in 2004 with outcomes to 2010, using a 1.5 Tesla scanner, if you have an abnormality and you have removed the abnormality, you have an 85% chance of achieving seizure freedom in the short term. If you don't remove the abnormality, success rate falls to 16%. If you have a normal MRI and you operate, the likelihood of achieving seizure freedom is much lower. If you can resect what you can't see, it's 44%. And if you don't resect what you can't see, it's less than 3%. And what that means is these are the patients who are MRI negative who have abnormalities on ictal SPECT scans or interictal FDG PET scans or some form of source localization that helps you guide your evaluation with some kind of invasive intracranial monitoring. So those people can achieve seizure freedom, but it's lower than if you have a clear thing to go after. And these are data from the MELD study, which is looking at focal cortical dysplasia and looking at delays to surgery. So there are 2 points here. One is that if there are delays in surgery, you are less likely to achieve seizure freedom. That does not reflect the severity of the entity. Those are the lines you can see. The other is the outcome depends on the underlying pathology. So type 2 dysplasias do better than type 1 in outcomes. The other finding, though, which was quite striking, is this group, which has imaged probably 1,000 children now from many centers across the world, some centers had 1.5 Tesla MRI, some centers had 3 Tesla MRI, and the outcomes are superior for those with a 3 Tesla MRI. So there is some advantage to the higher magnetic fields. Okay, so this is show and tell. This is, this is like, vascular. This is a cavernoma. It has nice dark signal. It's kind of irregular, and that's because the black stuff is blood from hemosiderin, which causes disturbance in the magnetic field. This is a classic bag of worms, and that's an AVM, and this is someone who has a wedge-shaped lesion in their head, which is an old stroke. So these are the 3 major vascular things that you are looking for. Then there are brain tumors. And these are different brain tumors that you can see. I hope you can see the abnormalities here. This is an oligodendroglioma. This is a ganglioglioma. No contrast enhancement. This is a DNET, which is something between a tumor and a dysplasia that grows very slowly, so it's not really a dysplasia. But they are well demarcated. They're relatively easy to see, and they tend not to be all that tiny. Is everybody happy with that? Then there are nasty tumors, right? So, well, the pilocytic astrocytoma is not so nasty, but you can see, I'm sorry. This is not good. Okay, let's try this. So obviously there's a big hole here. That's the pilocytic astrocytoma. And these are low-grade tumors here, which are invasive, that may or may not be contrast enhancing. And here is a very, very, very nasty glioblastoma, which is contrast enhancing. The outcome there obviously is very bad. So those are the tumors. And this we saw yesterday is mesial temporal sclerosis. So the characteristic findings are a small hippocampus, which is bright and loses internal architecture. And I always look to see if there is an anterior dysplasia going along with that finding. So this is mesial temporal sclerosis, which, as I had said, is something we see less of in children in the last while. There are data to suggest that if you do analytics based on volumetry and size and shape, and this is work from, from the Bernasconi's group at the MNI, showing that you can identify different signal processes in the amygdala and in the hippocampus. You can identify bilateral atrophy in this way, and these people have a little bit lower likelihood of seizure success. If you have unilateral atrophy, the seizure-free freedoms are quite high, around 90% short term. If you have bilateral mild atrophy, it falls a little bit, and if you have bilateral hypertrophy, success rate is 44%. This does not dissuade you from surgery, because that still may be a better option than medicines, but it will modify what your expectations are for the family. Okay. These are malformations of cortical development. I am not going to read this. You can take slides of this. You'll have access to this. But this is Jim Barkovich's way of looking at classifications of malformations of cortical development. And it is a schema that one can use to look at these entities. This is distinct from the ILE classification by Palmini and then done subsequently by Blumke, looking at classification of focal cortical dysplasias type 1, 2, and 3, which I will spend more time on. And these just have to say that your abnormal neuronal or glial proliferation, there's abnormal migration, there's abnormal cortical organization, and then there's other, and that all reflects the time in which brain cells migrate and move and prune their synapses. So this is the classification of Palmini, which has been modified by Blumke. So type 1 focal cortical dysplasia is abnormal lamination, either vertical or horizontal or both. Type 2 is dysplasia with dysmorphic neurons. A is without balloon cells, B is with balloon cells. And then type 3 is a combination of 1 or 2 with something else, with or without hippocampal sclerosis, with or without a brain tumor, or adjacent vascular malformation, or to something else. And then there's a new entity called white matter mild malformations of cortical development, which I'm not going to talk much about. And what does this arise from? So what happens is when your cortex is generated by migration of cell lines from the periventricular area, if there is a mutation in a mother cell, then the daughter cells will express that mutation, and they will then be abnormal when they get to, if they get to their place where they're supposed to be. So these dysplasias tend to be wedge-shaped. And if you look at the genes harbored within the abnormal cortex, you will find abnormalities anywhere from 2 to 50% of neurons. And if you look at the type 2 focal cortical dysplasias, the abnormalities are invariably in the mTOR pathway. If you look at the type 1 genes, then the genes are much different. They tend to be involved with other molecular mechanisms. The example here is SLC35A2 for those who wish to know. There are also interneurons that come from the thalamic eminence that create the interneurons, the inhibitory neurons of the cortex, and those have not yet been implicated in this process, but I suspect they are. Okay, so the hallmarks of a focal cortical dysplasia are the cortex is thickened, there is blurring of the gray-white junction, and there's increased T2 signal or flare signal in the focal cortical dysplasia. So they are bright, they are thick, they are blurred. And if you look at a little bit higher level, they disrupt sulcation and gyrification, which you can see with some analytics. So this, and also I will point out, the red circle is not normal. Red circles and yellow arrows are highly epileptogenic. So here is blurring on the T2 image, blur, blur, blur. And here you can also see blurring and thickened cortex. So this is a focal cortical dysplasia. You cannot tell based on this whether this is type 1 or type 2. These are the transmental dysplasia with balloon cells of Taylor, or focal cortical dysplasia type 2B. These findings are pathognomonic for this entity. They are kind of a form fruit of tuberous sclerosis, which is just isolated to a germline. And you can see this mushroom shape or this wedge-shaped abnormality right here, which is bright on T2. You can also see it here on other imaging and also on T2 over here. So these, again, are the anomalous stem cell mutation in a mother cell that then affects the daughter cells. And that extends along the pathway of neuronal radial glial development. And this is something that you see after the 25th cell cycle. The hemimegalencephaly you see with cell cycles less than 10. Okay, so here is hemimegalencephaly. So this involves the entire hemisphere. The hemisphere is large. The ventricles are large. They're kind of club-shaped. And there is change in the white matter signal that you see diffusely across the hemisphere. And these tend to be mTOR pathway mutations before the 12th cell cycle. Are we happy with that? Lovely. Good. Okay, so here's an epileptic blue arrow. So this is unilateral left temporal epilepsy, and this is white matter hypomyelination. And when you look at this closely, for most of the time, you find a focal cortical dysplasia. It may be type 2 or it might be a type 1. But I think that you can see, and this is what we were fussing over with yesterday in the case conferences, or I was facing over. So you can see relatively clear gray-white junction here. You can see the fingers of the white matter here, whereas on the right, this is a glass ground bright appearance. On the T2 image, it's also fuzzy, and down here, this is very fuzzy, and this is not fuzzy here. So this is a temporal tip focal cortical dysplasia, which is also amenable to surgery. Okay, and here is the difference between a 1.5 and 3 Tesla scanner. You can find the abnormality on 1.5 Tesla. It's really not that difficult to see. It's right here in the mesial area. But on 3 Tesla, this is much wider and much more widespread here on the left side of the brain. So the 3 Tesla identifies the lesion a little bit more clearly. It also shows that dysplasia is more extensive than you might have seen in 1.5 Tesla, but it doesn't change the underlying diagnosis or what you do. But it may change how much you take out. So this is the bottom of the sulcus dysplasia. These tend to be type 2s. These are better. These are also, there's an epileptic blue arrow here. So I think you're kind of, this is a little bit off. It's right here, right there. You can see that on T1, T2, and FLAIR. And this is an example where magnetization transfer imaging, which is actually easier to do at 1.5 Tesla, identifies the abnormality at the gray-white junction, which is seen in the blue circle. You can see this rim of increased signal here at the bottom of the dysplasia. So this is easy to remove, and the outcomes tend to be really excellent. Okay, so here is susceptibility weighted imaging. So this demonstrates really the iron or calcium on the signal in the blue circle, and you can see with the red arrow, this is much more easily discernible than it is with the T2 weighted imaging. Okay, babies. Babies are a problem. They are made mostly of jello, and the best time to image a baby is very early in life. After you get to 3 months, the maturation myelination makes things really very fuzzy and problematic to see, and you don't really see them until you are older than 24 or 30 months. So as I mentioned, you really need T2 weighted imaging. And here's an example of a child who had seizures in the neonatal period, and the early imaging shows this very obvious dysplasia in the left mesial frontal cortex, which you don't see at 1 and 2 years. So when this is removed, eventually the child becomes seizure-free. So this is an example where imaging is seen as a baby, less than 1 month of age, that then the lesion disappears as the myelination progresses at an older age. And here is the converse. So here is a lesion which does not become apparent, not seen at 18 months, which is seen later at 4 years. And you can see that this person, this is symmetric, and then here, this is asymmetric. So there is a dysplasia here, the temporal tip on the left, which you can also see in the lower image. So here's an example where a dysplasia is not apparent at the hardest time to identify, malformations of cortical development, and focal cortical dysplasia, which are apparent later on in life. So if you don't see it early on, you need to repeat the imaging later in life. Okay, so here's another example of 1.5 Tesla, which is underneath the timer, which is 5 minutes and 25 seconds magnetic field, and 3 Tesla. Does anyone see the lesion? It's actually apparent, although it was not identified at the time that this was interpreted. So a PET scan was done because people thought the MRI was normal, and you can see obvious PET hypometabolism in the left temporal lobe, which is quite extensive. But when you re-review this, you can see this bright signal at the front of the temporal lobe on the left, which is a focal cortical dysplasia. Yep. Sister hospital. Not bad, not bad. But the thing is, once it's obvious, it's obvious. Right? Once it's obvious, it's obvious. But if you don't see it, it's not obvious. So, but this is just an example. But you don't see it at 1.5 Tesla. It's not there at 1.5 Tesla. It's there at 3. It's there at 3 Tesla. Is everyone happy with that? You can't see it up here, but you can see it down here. You would hard to see if you're looking at it. But anyhow, so this is 7 Tesla. So 7 Tesla confers some advantages, especially if you're away from sinuses. And here is a box showing the normal imaging at 1.5 and 3 Tesla showing an focal cortical dysplasia in the box at 7 Tesla. And these are just a couple of examples of that. And the claim is that 7 Tesla improves your yield by about 15 to 20%. Okay, and then you can also use computational detection of focal cortical dysplasias. And there are a variety of programs that are used for this. One is a morphometric analysis program, which compares on a box-wise basis your MRI to a database of healthy controls. There's also a surface-based machine learning algorithm, which is MELD, which automatically identifies focal cortical dysplasias based on heterogeneous structural MRI data from epilepsy surgical centers. And they are looking at the features I've discussed on FLAIR and T1 imaging of thickness and signal blurring and disruption of sulcation versus controls. And these are thought to identify abnormalities. They have a reasonably fair false positive rate, but they allow you to screen the MRI for suspected areas, and then you have to match what you see with the clinical characteristics of the epilepsy to see whether or not it is relevant. So here's an example of a 7 Tesla scanner. There's an abnormality there, but the MAP analysis shows a clear signal intensity where the red lines converge. Okay. And here's just another example of identifying a dysplasia where the red arrow is, and that abnormality is enhanced by using an MAP analysis. Okay. I'm just going to run through a couple of other pediatric syndromes. So this is tuberous sclerosis complex. You can see the hyperintensity on T2 and FLAIR imaging and the relatively hypointensity on T1 imaging. And these are, of course, multiple, and this represents an mTORopathy. The phacomatoses, Sturge-Weber syndrome, which actually you can sometimes easier see on CT because the cortex tends to be calcified with the blood vessels, and you can see the abnormality on the MRI. It tends to be unilateral. Of course, they have a trigeminal Port-Wine state, ipsilateral to this. There are deep targets to go after. These are periventricular nodular heterotopias. This is with the white arrow. You can see the abnormality lining there. These tend to be, they occur in boys and girls, but when they occur in girls, you think of FLN mutations. This is important because this is associated with ascending aortic aneurysms in young adulthood. Chris Walsh says everybody knows this. Not anyone in the audience knows this, so I'm now sharing that with you so that you know this as like one of those, why don't you know this kind of things. So the thing with periventricular nodular heterotopias is about 1/3 of the time the seizures are coming from the heterotopia. And you can remove this by some form of ablation. We happen to use lasers. Others, the seizures come from the cortex, where the periventricular nodule heterotopia sister cells have migrated, and a third of the time it's both. The outcomes are much better, obviously, when it's restricted to the periventricular nodular heterotopia. And here's just an example of showing a nodular heterotopia, looking at the cortical hypometabolism induced by the heterotopia, where the arrow is, and then the DWI tractography showing that the projection of the heterotopia goes to the hypometabolic region in the cortex. Taking out the heterotopia made this person seizure-free. But if that would not happen, you would go after the cortical region overlying that. Are you happy with the pictures? Good. You're welcome to the slides. Happy to make them available. Okay, so deep targets, hypothalamic hamartoma, early onset. See, what's that happens? The other talk is shorter. So that is a mirthless laugh of gelastic epilepsy. That's a real laugh. So these kids develop an epileptic encephalopathy. They have behavioral deterioration and really nasty rage attacks and a poor response to medications. The MRI is diagnostic. The EEG should be done to confirm the diagnosis, but the surface findings may be deceptive, so you can't be guided by that. And you get seizure control in many, although not as high as people think, with laser ablation. Have to worry about memory impairment by nicking the mammillary bodies or the fornix. So you're disconnecting the hamartoma, and here's an example of that. You can see, well, here that is. Right here is quite obvious. This one is in the third ventricle, and that can be, that's hamartomatous tissue, and it can be removed. Hemispheric disease, the main things for hemispherectomy are hemimegalencephaly, diffuse cortical dysplasia, stroke, and Rasmussen's encephalitis. Rasmussen's has a progression of atrophy, usually beginning in the perisylvian area, with underlying T2 abnormalities that progresses with time, and hemimegalencephaly, which we have discussed previously. Okay, so genetics and imaging. So genetics diseases may have abnormal MRIs, including focal cortical dysplasias, malformations, cortical development. This is true of tuberous sclerosis, mitochondrial disorders, and peroxisomal disorders. Abnormal imaging may hint at a genetic disorder, as in TS, Walker-Warburg, or other somatic mutations. There are things like lissencephaly and schizencephaly, and here this is bilateral, where this establishes the cause of the epilepsy and may lead to a search for genes, but the prognosis for seizure control is poor, and they are not candidates for curative resective surgery, although they may benefit from palliative surgical approaches. And here is just an example of abnormalities suggesting a metabolic cytopathy here, a metabolic disorder with the increased signal in the midbrain, the cerebellar atrophy, and the MR spectroscopy showing a lactate peak. This thing really doesn't like me, does it? Thank you. Because I'm at my conclusion. Thank you. Thank you. Okay. So that gets us, so these people are not so good surgical candidates, diffuse bilateral abnormalities, seizure focus overlaps with eloquent function, genetic epilepsy, although there are some exceptions, metabolic disorders, and what are viewed as progressive disorders. But properly selected patients with bilateral focal abnormalities like TS or genetic disorders with clear focal abnormalities may benefit from resective surgery or palliative surgery. So there is no substitute, absolutely no substitute, for a high quality, high resolution MRI epilepsy protocol, preferably at 3 Tesla, reviewed at initial evaluation and after non-invasive evaluation by skilled readers of pediatric MRI, or if you're an adult MRI. So most people require MRI, especially at focality or young. The classical absence epilepsies do not require this. When preferably at onset, certainly after 2 medications have failed the child, you can establish the etiology in 1/4 of patients, identify prognosis and direct treatment, and you can identify subjects at the outset who may benefit from epilepsy surgery, and if you do that earlier, the outcome will be better than waiting later. So with that, that is the end of the talk. Thank you very much. Okay, everybody please stand. Everybody standing. Everybody throwing around. Throwing around. Like an MRI scanner, you're spinning the proton. And then we're sitting down again because you have to listen to me for another half hour. Now we go to the next talk. And this should be 20 to 25 minutes. Okay, so now we're talking about functional MRI, which is kind of what I do. And we're going to talk about how this is used in patients with epilepsy. And I'm still me. And George Washington and the bear still have eyeballs. Okay, so functional MRI, I mean, you want to confirm the focus, and you can do that with interictal and ictal fMRI, but that really is rather uncommon. You're really using functional MRI to identify areas to spare during surgery that you do not want the neurosurgeon to touch. How many neurosurgeons do we have in the audience? We were neurosurgeons yesterday. They all disappeared? Ah, very sad. Okay, so you can identify areas to spare sensory motor cortex, language, and memory. We are not talking about experimental uses for functional MRI. What fMRI provides is a non-invasive way that is validated by WADA test and cortical stimulation to evaluate these functions. And you can do this in a really smart 3-year-old, but mostly those more than 4. It provides whole brain temporal and spatial resolution. It can lateralize and localize functions. It is repeatable, and you can use multiple tasks to target different functions that you're interested in. How many people have seen X-Men? It's now an old movie. This is Magneto. Does anyone know how Magneto escapes from prison? Stunned silence. He sucks the iron out of the hemoglobin in the guard in his plastic dungeon and creates a dagger with which he escapes. So Magneto is the basis of functional MRI. You will not forget that, ever. So this is the blood oxygen level dependent technique. It is a relative and indirect measure of cerebral activity. It provides a spatial resolution of a couple millimeters and a temporal resolution of about 5 seconds. If you're really clever, you can get this to be down a little bit. It looks at a broad network, not serial processing, and you can identify areas associated with, but not necessarily critical to, functions such as language, and different paradigms can probe different aspects of language. What happens is there is a different magnetic resonance signature when your hemoglobin is oxygenated from when it's deoxygenated in the upper right-hand corner, and when your brain is called upon to do a task, there's a regional specific increase in blood flow, and as a consequence, a different ratio of oxygenated hemoglobin to deoxyhemoglobin, and that's what you're picking up. So if you elicit this kind of vascular response, you can pick up the signal on the functional MRI. Okay, and I did this again here in a bigger picture, and the delay here is approximately, this response kicks in after about 2 to 3 seconds, and it reaches its peak at about 5 seconds. Okay, and you have to compare 2 conditions, right? A task or a rest condition and the active condition or the task of interest. So for sensory motor mapping, this is mostly for extratemporal lobe epilepsy, frontal parietal. You're looking where that motor cortex or sensory cortex is in relation to a tumor or a lesion or some other thing, and you can identify the motor and the sensory strip, and it agrees with evoked potentials by within 5 millimeters. So you could do this with finger tapping, you can do this with tongue wiggling, or foot tapping. Foot tapping moves the head, so it's a little bit harder to do. Sensory, you could do a visual flash the way you would with an evoked potential. You can listen to tones, and you can brush or tickle the surface of the skin and hope the person doesn't laugh and move in the scanner. So here's an example. This actually happens to be the child with the bottom of the sulcus dysplasia because he was a clarinet player and his mouth area was important to the family. So you can do tongue wiggling, which shows the lower motor, the mouth area. You can do finger tapping, which shows the motor cortex. You can also see the supplementary motor cortex as well here. And if you looked at the cerebellum, you could see dentate nucleus. And left foot tapping shows the right motor cortex and the SMA. So you can map the homunculus in this person to help plan and guide surgery. That's the easy stuff. Language mapping provides not only lateralization, but it turns out location of language function. So you want to use a simple task that patients can do. It identifies a broad network and has to have high contrast between the two conditions. And it has to be analyzed on an individual basis because you're operating on an individual. You're not operating on a Talairac atlas. And you have to view the thresholds from a clinical, practical point of view. The image maps you get should be viewed at a series of thresholds because there are differences in signal and motion that may alter the map, but you can read through that if you have skill. How many people here are right-handed? How many people here are right-handed? 5 people are right-handed? 10 people are right-handed? How many people here are left-handed? This is unusual. Most left-handed people raise their right hand when I ask that question. Everybody who's left-handed raise their left hand. So if you are right-handed, the likelihood that you are left language dominant is 95%, but 5% will not be. And if you are left-handed, the likelihood of being left hemisphere dominant is about 78%. So about a quarter to a fifth of patients who are left-handed, especially if acquired, will have atypical language representation, and you can't tell that just by looking at the MRI. You need to do that by having some form of structure of functional test. Okay, and look at that, I even have the numbers up there. So this is based on selection of tasks. We use multiple tasks and individual analysis. This has been correlated with electrocortical stimulation, with the WADA test, resection, and ultimately at the end of the day, resection of fMRI negative areas, if you have a decent study, is safe, and resection of fMRI positive areas you do at some peril. Okay, so I repeat tasks because tasks targeted at the same region increase reliability, and you want to target the different aspects of language because it depends where your focus is. So if your focus is frontal epilepsy, then you want to know where Broca's area is. If you have a temporal lobe epilepsy, you want to know where receptive language is. And this is important for that resection. Multiple tasks increases inter-rater agreement. It does not increase agreement with the WADA test or inter-amital test. So there is very good data that these agree with each other. It is very rare to have absolute discordance between a WADA test and an fMRI. Most of the disparity is partial, and in these, fMRI tends to be a little bit superior to WADA, and both are excellent but not in complete agreement, and they predict post-operative language capacity. Okay, so there are a variety of paradigms you can use. Verbal fluency paradigms, generation, for example, to letters or to categories, gives you very strong activation in frontal area to identify Broca's area. You can do decision tasks. These also identify a similar area, but a little bit different than the verbal fluency tasks. If you want to understand language, then you should use something more than single words. And comprehension tasks identify the temporal receptive language areas, and auditory comprehension does the same thing. And you can combine these tasks, which is what we have done. Oh, but first, this is me. I show this slide for 2 reasons. The first is we had thought that the background noise of the scanner would account for auditory processing for a language listening to story test. And that's the upper limit, that's the upper slide. It does not. There's more activation on the left than on the right, and for these images, left is left and right is right. So there's more activation on the left than the right, but there's a lot of bilateral activation. That's because listening to me talk, if you're awake, will activate both sides of the brain, but comprehension comes from the left. So we then use reverse speech that suppresses the first and second order auditory comprehension, so you see much less activation on the right, and you isolate the language comprehension areas on the left. The other reason I show this slide is to demonstrate to people that when they talk to me or at me, something happens between my ears. That's a joke. Okay, these are the tasks. We have a category decision task, which mostly activates the left Broca's area. In contrast, listening to stories is a very strong activator of the left temporal cortex. Reading the same stories that you listen to gives you much more diffuse activation, still within the distributed language network that is bilateral and anterior and frontal. And if you do a auditory description decision task or a sentence definition task, such as what is a king's hat is a crown, gives you very strong lateralization and very strong activation in temporal and frontal areas. That is the task that we rely on most heavily. So here's an example of a bunch of tasks. You can see the tumor in the left anterior temporal lobe. We've also added a verbal fluency task, which is quite helpful. And you can see that across all these 5 tasks, there's very strong activation in left Broca's and in left Wernicke's. You can see the 3D reconstruction on the far right. And you can also see that the activation is always posterior to the lesion. So it is reasonably safe to go ahead and take out the lesion as long as you don't go too far back. Okay. These are different patterns that we see. So the person on the left is left hemisphere dominant. The next column is someone who's right hemisphere dominance across these 4 tasks, showing activation in homologous or homotopic regions on the right compared to the left, someone with bilateral activation, and someone with cross dominance. Those are the patterns that we see. And Jeff Binder in Milwaukee demonstrated that comparing semantic decision, that a semantic decision task predicts postoperative naming, which is the Boston naming, and that the relationship between fMRI determined language laterality had a stronger relationship with outcome than did the WADA LI. So what you're doing is you're identifying a language dominant cortex, and when you operate on a language dominant cortex, there's always a risk that you will have some decline in language function, although you don't want to make someone aphasic. And no one here was aphasic. So some activated areas are not critical, but critical areas because of other aspects of language, such as attention and concentration. And critical areas may not be activated if you haven't designed your paradigm well, or if there's a reason why the bold response has not worked. So false lateralization occurs when homologous non-dominant activation is misinterpreted as true activation, and we will see an example of that. And null activation should be interpreted, should be carefully interpreted, and not as no function. So there are 4 conditions in which the bold response is impaired, and that means you will diminish the activation of true language areas, and you may misinterpret the contralateral activation as a dominant hemisphere. That occurs when there is a large glioma with edema and mass effect. It occurs in an AVM where there's a vascular steal, when you cannot increase blood flow beyond what the body is already doing. When you have critical arterial stenosis, which is not an issue for me, but it is for my adult colleagues, and most importantly, a case report from Miami Children's Hospital in a children in a postictal state. This child, image is above, and then 2 weeks later, had 20 seizures on the morning before his functional MRI, and the signal in the postictal temporal lobe was diminished. And when that was repeated, the child was found out to have language in the cortex that they were interested in operating on. So I always find out when the last seizure was and how severe they have been. And I use that to interpret my studies. And Homer, the bard with no brain, has very little activation. Okay, so we also compared our 4 tasks to cortical stimulation. This is mostly using object naming, so it's not really a fair comparison. But the take-home point here is that for the word definition task, or ADDT, the sensitivity was 80% and the specificity was 72%. And that means that if it's activated, it's true, and if it's not activated, you're okay to take it out. And these are just the curves of that analysis. We also looked at what happens when you take out activated cortex based on the resection cavities in the functional MRI, and it turns out that the volume resected is not related to postoperative naming decline, but the volume resection of activated areas in relevant regions is associated with postoperative naming decline. So if you take out activity in the supplemental area during a language task, that doesn't matter. But if you take out tissue in inferior frontal cortex or superior temporal gyrus, that is going to affect your postoperative outcomes, and you should not be taking out those areas. Here are data from Madison Burrell's work combining our data sets from NIH and Children's with 118 controls and 220 patients. Of the patients, 2/3 have a left focus, 1/3 have a right focus, half are children, half are adults. And the normal controls, and this is looking at an asymmetry index between the Broca's area and Wernicke's area, and the controls are all in the upper right-hand corner because that's left temporal and left frontal dominance, and only a couple people are outside that. So those are the normal people who are left hemisphere dominant. The patients are all over the place. Most of the patients from the upper right-hand corner, because most patients are left hemisphere dominant for language, but not everybody is. And their pattern is not one. Actually, there are many scattered patterns of language dominance in these patients. So what we learned from that is approximately 1/4 of our patients with epilepsy have atypical language representation compared to 3.5% of controls. That atypical language is associated with atypical handedness. This is not new news. And atypical handedness is associated with right Broca's lateralization, so proximity between Broca's area and motor cortex is important. If you have acquired left-handedness, then that increases the likelihood of shifting things over to the other side. So the earlier age of epilepsy onset is associated with increased risk of atypical language representation. So it is very unusual to find someone with atypical language dominance if the seizure onset or the cause of the epilepsy occurred after the age of 6. And when you see that, that represents the normal variability that you would expect in a population, which is 3.5%. That atypical Wernicke's lateralization is associated with early seizure onset, but that's not true for Broca's. We do not find an effect of age at scan, duration, or gender, and we believe these findings represent the differential maturation trajectories of regional brain development for language function, which mature later in the frontal cortex than they do in posterior receptive cortex in the left temporal lobe. I'm going to move to memory and then interictal and ictal studies. So memory is, if you remember, so we are looking at explicit or declarative memory, and we are looking at episodic memory, because that's what makes you amnestic. So there are a variety of memory paradigms that can be used, and that leads to material specificity. So verbal encoding tends to activate the left hippocampus, which is typically the left dominant language hippocampus. Scene decision or encoding gives equal activation. Mental navigation, Roland's hometown navigation test gives you bilateral activation. Face recognition and pattern encoding give you activation in the right hippocampus more than the left. You tend to get hippocampal and perihippocampal activation. And activation is linked to performance, and fMRI has not predicted the risk of amnesia. So this is data, these are the first studies done by John Detry looking at scene encoding compared to a blank control, showing bilateral activation in the hippocampus. And what he found was it was the activation in the hippocampus to be resected that predicted memory outcomes. So some people had felt the more activation you had on the other side of the brain, which would be hippocampal reserve, would spare you from memory deficits. That is not true. It is functional adequacy in the hippocampus you're resecting that predicts your memory outcomes. I would also add data from our group and from Great Ormond Street would suggest that if you take out a hippocampus in a child less than 12, you will not experience any decline in memory function. And it is only when you operate on the hippocampus, which is normal appearing after the age of 12, you start getting into the difficulties of memory loss. And this is because we postulate that memory specificity does not occur until the early teenage years. The best and coolest task is an event-related task done by John Duncan's group with Sylvia Bonelli, using an event-related forced encoding protocol. So you ask someone to remember something, and you only analyze the fMRI signal for those items which were properly encoded. And when you do that, and you do this for verbal encoding, this is looking at words, you find very strong activation in the left hippocampus. When you do that for face activation, you find activation in the right hippocampus compared to controls. And this activation, the magnitude of activation in these areas predicts, when you operate on that hippocampus, declines in measures of memory, of verbal memory performance on the left and on visual spatial performance on the right. This was an excellent study. So interictal fMRI is an event-related, so this is source localization. You can do this with MEG, you can do this with EEG, or you can do this with functional MRI if you have the fancy equipment to do this. So you're looking at the hemodynamic response, which was on my third slide, induced by the event of an epileptiform spike and slow wave. This is a post hoc analysis after you identify the spikes, which you can do in many ways, and looking 5 seconds later to look at the bold response. You need probably, and you can get away with 5 spikes, but most people need about 20 spikes. And anyone sitting in an MRI, about 2/3 of patients will have adequate data to analyze. And as with anything, you have to worry about interictal spikes in relation to the ictal focus, which we'll get to in my penultimate slide. So this is one of the first studies that did this. So the spike is where the arrow is. You turned on the scanner, 5 seconds later, you get the hemodynamic response. When you map out the hemodynamic response relative to periods when the EEG is quiescent, you can identify quite nicely a neocortical increased bold signal corresponding to the interictal source localization. And you can also identify mesial temporal origin of epileptiform activity. Sean Gottman at the MNI, before he retired, spent a lot of time with looking at functional MRI, both ictal, which he has a small series of, and interictal studies. And his observation was that when you do source localization with MEG or EEG, you are probably looking at the propagation of the signal. And you may be deceived in the origin of the epileptiform activity. Whereas he argued that when you do functional MRI, you are looking at the bold signal associated with the initiation of the spike and slow wave and not its propagation. So this is a small case series demonstrating and confirmed by stereo EEG that the bold signal from the interictal fMRI analysis off of EEG was better localizing than was source localization from other methods. Just a thought. And as I promised, I was going to finish early with this talk. So fMRI is reliable for motor and sensory mapping. It is reliable for language lateralization and localization. The task you use should be redundant, because if you have redundant tasks, you're more likely to have replicable results, and you should select the task targeted after the area of interest for resection. There is agreement with invasive methods, both the WADA test and cortical stimulation. It is safe to resect fMRI negative areas. You resect fMRI positive areas. That carries a clear risk. You can predict the surgical outcome for language and memory. It is a guide for motor, sensory, and language localization. It is reliable for hippocampal memory, but untested for predicting amnesia, but it's really labor intensive to do the memory fMRI. And interictal source localization is reliable for selected patients, and ictal localization is rare, but does occur. So there are conditions where the bold response is disrupted physiologically, and the data may be falsely lateralizing if you do not take that into consideration. And the main thing here is post-ictal disruption of the bold signal. No activation is non-diagnostic, and if you have funny results or non-diagnostic results, you should then move to a test which is more disruptive, either cortical stimulation or a WADA test, or repeat the study. And that is the end of my final talk. We have slain the seizure dragon like that, says the young princess. So thank you very much for your kind attention. I didn't have any post-ictal effects on the laptop for the second talk. Is Dr. Rob next?
Yes.
Dr. Rob is next. I can field any questions?
I have one question, please.
Okay.
You showed us the EEG MRI.
Yep.
And event-related MRI, once you've got a spike, a few seconds later you start your scanner, right? It's still not temporarily time-locked, isn't it?
So I showed you the first studies. So in the first studies, they ran an EEG, and when they saw a spike, they turned on the scanner. And the scanner generates artifact in the EEG, which is why they were not running the EEG when they ran the scanner at the same time. Subsequent to that, there are programs that allow you to run the EEG continuously and there will be artifact on the EEG which you can computationally fix. So that in the old days, you would wait till you saw a spike, you would then push the scanner and see what you got. Subsequent studies just ran the EEG continuously. They looked at the spike, and then they looked sequentially at where the peak bold response was in terms of the delay of the spike. And it turns out the peak bold response is at about 5 seconds, but for some people it's at 4, so for some people it's at 7. So what Jean Gottman does, he effectively does a sliding window to look at the peak bold response for any given spike.
Okay.
But the equipment, the cost of the equipment to have ongoing EEG in a scanner is not cheap.
Thank you, Gael, for this lecture. In the beginning, you talked about
excuse me, can we
سؤال واحد
postpone
يعني سؤال واحد
يعني احنا في
خلصت
متأخرين
خلصت
جدا
هو
في
بس
تايم
في
لاج.
اصل في البيجيننج قال ايه؟ قال سي تي
طيب يعني انا هدي حضرتك 1 minute بليز يعني عشان بس اتفضل.
in the beginning of your lecture you said CT if MRI is not possible. I read that it's not good to make CT for children because it is radio problem in radiology. Is that practical in USA? That you don't use CT for children?
Well, so CT confers radiation, and it's false information. So I prefer to get an MRI unless the child is an extremis and the MRI is not available. I work in a tertiary referral center which thinks very highly of itself, and I cannot get MRIs in the emergency room. When I have consults in community hospitals, they get the MRI within 15 minutes of the child stopping disease. So it's doable in the right setting. So, I mean, to me, I try not to get CTs. I prefer MRIs because that's the diagnostic test of choice if you have the time to allow it to do that.
Okay, thank you.